have the pleasure to present on this topic, and I titled this talk as Autoimmune Hepatitis Treatment with a question: are old/current therapies good enough? And again, the old/current is probably a little bit of a play on words, and we'll kind of pepper throughout the talk today as one of the major themes as well. But let's get started. My aims for this talk will to review current AIH treatment strategies. And again, when I use big words like strategies, means just how I use medications that are currently available to treat the inflammation that we see with autoimmune hepatitis. I hope to highlight maybe in some aspects where current treatment falls short. And that's not to necessarily mean it falls short for everyone, but there are patients that are unfortunately left out of excellent results, and we'll talk a little bit more about that. We're going to identify those patients that probably need better treatments, and hopefully the future of AIH research will help to enlighten this and provide better avenues. And then I'm going to show some examples of true treatment innovation in AIH with some drugs that are in clinical trial but have been used, but also some exciting things in the upcoming year to associate with the Autoimmune Hepatitis Association as well. So, as we've been talking a lot about treatments and those aims, you realize I'm not talking about a cure. And as of now, I don't know of any autoimmune disease that really has a proven definitive cure, instead of maybe for AIH where we could replace an organ that was destroyed, or in type 1 diabetes with islet cell transplants that can be done. But now what we have is really just treatments, and these treatments are a means to control disease or control inflammation, much like Dr. Sebade said earlier today. And I think in order to understand why there is no cure, I think it's important to compare maybe some diseases that are simpler to understand. Now, celiac disease is not a simple disease. Celiac disease is a disease that's autoimmune in nature and is characterized by autoimmune destruction or inflammation of the small intestine. We know celiac disease has genetic causes. There are risk factors, and these letters and numbers here indicate a gene. These genes also are important in AIH, or at least around the area of that gene. But having one of these genes increases your risk of celiac disease about 3%. Having both of them increases your risk about 10%. The problem is there are other genes that are probably important, but in fact, the way that those genes interacts with the environment, in the case of celiac disease, gluten is one of the most important exposures that can then trigger the onset of celiac disease. And gluten is a name for proteins that are found in wheat. This is such as like rye, barley, but it's really a cross between wheat and rye. And gluten really helps food maintain their shape, but we know where gluten is. In fact, if you expose gluten to patients with those gene pairs in risk, there's a possibility you could evolve or develop celiac disease. AIH is a little bit different. We know there's genetic risk, and in fact, having this risk factor of DRB3/4, these risks, or these genetic pieces, can increase your risk about 5 to 6-fold. However, there's obviously patients that don't have those genes, or have those genes and don't have autoimmune hepatitis. And one area of research, at least at any university, is understanding what are those environmental factors. And Dr. Bitterman spoke to this earlier, and we've published some data looking at some simple things like coffee use, which you may find funny, but it seemed like coffee use could have been protective in cohorts of AIH patients. But also things like urinary tract infections and exposure to antibiotics may also increase the risk of patients that carry these genes as well. Therefore, because this disease has the genetic risk baked into patients, we can only help to really control the disease at this point in time, not necessarily cure it. This slide really shows all the medications that is in my armament for the use for patients that have autoimmune hepatitis. And I'm going to expect many of you have a love-hate relationship with some of these drugs on this list. And some of you may recognize all of these. Some of you maybe only recognize 1 or 2 of them. Because we have a long list, and again, you may be surprised we have so many that we can use. It doesn't mean all hepatologists use these either. It also doesn't mean that these drugs work well, and we're going to talk a little bit more as well. But I think one thing that's important to know is these medications in this list doesn't change very often. And in fact, really the new kid to the block, budesonide, which has been utilized for the treatment, at least after the diagnosis of autoimmune hepatitis, to quickly control inflammation. was really only started to be applied in the past 5 to 10 years. But beyond that, look at the other dates in terms of when these medications were approved by the FDA for use for not AIH, but for some other indication. Many of you that are on azathioprine as the frontline or first-line medication and its sister drug, 6-mercaptopurine, which are essentially the same compound, but just different steps in the pathway of their destruction. These medications are the first line, but they've been around since the 50s. Again, compare that also to the other piece that we often add to patients with AIH, prednisone, in a similar decade as well. Again, budesonide has helped many patients. And we're not going to talk about the way that we approach the therapy to AIH, but I will say budesonide has helped many patients that maybe didn't have such severe inflammation at diagnosis or with subsequent flares that doctors could get away with budesonide therapy and have limited side effects from steroids. Budesonide has been nice because it goes through what's extensive first pass hepatic metabolism, meaning once you swallow budesonide, it has gone directly to your liver where it's metabolized, and the blood leaving the liver does not have budesonide in the blood. I often tell patients it's like taking steroid and painting it directly on the liver. The problem is budesonide failure is known, particularly in patients that have severe inflammation. Therefore, many of us hepatologists don't mess around with those patients, and we still rely heavily on prednisone. There is other strategies, and we typically call these second-line therapies. And actually, every other medication on here is really a second-line therapy, but I've reorganized it a little bit. Many of you may know Cellcept, also Myfortic, which again is a similar compound, and then tacrolimus and Prograf. The other ones that are a little bit more uncommon to you maybe are the things such as everolimus or sirolimus, which I use sirolimus a lot at IU for a variety of reasons, which we could talk offline about at some point. These compounds are also fairly old as well, but they may provide some relief to some patients when they're not necessarily responding well or they have tolerance issues as well. Outside of that, we have kind of what I call the third line or tertiary line of last resort when patients are not responding. And in fact, rituximab, which we'll talk a little bit about later, has been around since the 90s, is typically used as a chemotherapy drug to eliminate B cells, as well as Remicade, which was originally used for the treatment of inflammatory bowel disease. And then cyclosporin, very similar as well. But all these have significant toxicities, and none of them are perfect, and none of them cause 100% of patients to go into complete remission or lower their liver tests. I think what is important is to really look at what these medications are doing. And in fact, if you've ever sat and thought, I take this medication every single day, what is it doing for me? And in fact, we are targeting with those medications something called autoreactive inflammatory cells. And that'll just be the generic term that I use all day today. These cells are what is driving the inflammation in the liver. And in fact, that's inflammation that is causing potential liver fibrosis and progression of liver disease, in the hopes that if we can control those or turn the dial down on their overreactivity, that you can actually improve liver outcomes for patients with AIH. So in the first two things, how do these medications control? Well, there's really only a few ways you can control the immune system. The first one is to limit the function, how those cells act, or the number of them, of those autoreactive inflammatory cells that cause liver injury. The other aspect, which is actually a little bit more rare, is to block the action of things that these cells make that drive the activity of those cells as well. These are called pro-inflammatory substances. They're different molecules that basically rev these cells up. And what you'll find, again, this is a very complex cartoon, and it's not so important what the mechanisms that you see in the graph are. But more important is the limitation of the function or number of cells basically are being done by all the frontline agents and actually some of the second line agents. So in fact, we're hitting a lot of the same strategies, even though it's going through the same pathway. All these downstream go to the T cell nucleus and really helps to limit its progression, its survival, its proliferation, and its activity. It's really not taking a targeted hit or approach, but we're taking more of a blanket and placing it over the immune system. Whereas sirolimus is a little bit different. Sirolimus can do some of those things too, but it also can block that second point, some of the action of pro-inflammatory substances through something called the mTOR pathway. Not so important now, but again, I want to highlight this because when you start to look at the other things that could improve inflammation or decrease autoreactive inflammatory cell activity, we don't have many agents that are available. So one of the other ways is you can decrease or limit the production of substances that these cells make that attract others to where they're actually active. Another way is to actually prevent where those inflammatory cells how they get to the liver and how they drive inflammation. These cells have to go through blood vessels and stick to them and stay put. So there is some strategies to think about how can we limit their ability to stick there in the liver. And then finally, a very interesting one, which we'll talk a lot more about, is how do you enhance other pieces of the immune system that can tell those cells to basically be quiet and really restore what we call homeostatic balance of the immune system? How do you get things to even out and kind of shift to more of a kind of even keel type of strategy? So how well do patients do with the current treatment? And I think we have to look at survival rates to be a little bit morbid. And this is data from a non-transplant center, I want to mind you. And again, we don't have a lot of excellent data here in the United States in terms of overall outcomes. However, we think if you take a whole population at large, that includes young patients and old patients, the 10-year survival rates of patients treated with these regimens is 91%. So 91% of those patients are alive at 10 years. If you push it a little bit further, we can go up to 70% or so. So these are actually not that bad. In fact, we generally say if patients can control their liver inflammation, their overall outcome and survival should be similar to that of patients the same age and gender, but without autoimmune hepatitis. That may be a little bit different if patients actually have liver dysfunction or cirrhosis at the time of diagnosis. If you look at it a little bit differently, if you think about the 10-year liver-related mortality, so what is the risk of a patient dying because of their liver disease after 10 years? And that's about 7%, so a little bit lower than that 9% seen in the 10-year survival, looking at all things that kill patients. But this 7% is actually similar in other countries. So it does tell us that, in fact, across the world in different continents, providers are probably doing about the same job with the therapies that we currently have. I'm going to ask our first poll, and this is a very generic question, but I love a single question. Are you currently satisfied with your current treatments for AIH? And in fact, there is some fluff behind this that you can either be not satisfied because it doesn't work, doesn't control your liver inflammation, or you have side effects from it, or you're intolerant. The idea is that, do you think that there's something better out there or something that could be better? I'm gonna let this go for another 5 or 10 seconds because this is a really important question. And we'll end the poll now. I'm going to share the results. And I know this is not necessarily showing those patients that are on prednisone specifically, because that actually may be different too. But overall, it shows that actually a quarter of our patients are very satisfied, with another decent group that is mostly satisfied. But I want to call attention here to, is there's probably close to 35% that is at least somewhat satisfied or below. And I think that's a real problem. And again, that's just a patient perspective. Moving on. Thinking about how good the treatment paradigm is that we have, we've heard things from patients that I want to share. We know that these medications have to be taken daily. They have to taken by mouth. Some patients are not necessarily compliant because life gets in the way and people are busy. It also requires that we have to monitor labs because there are significant side effects that come along with these medications. Outside of that, we apply these therapies to patients, no matter young, old, of different races. We don't know if there's any difference in responses or if anybody would actually provide, tolerate something better than another choice. There's no individualized therapy, at least with these strategies yet. Other issues that come along with the current treatment is about 10 to 15% patients are intolerant, at least first line. So speaking specifically to azathioprine, the development of nausea, vomiting, or upper GI symptoms impairs the ability to take it long-term, therefore shifting to something different. Side effects impact these medications as well, up to 15%. Patients that don't respond or have persistently abnormal liver tests or failure of therapy constitute another 35%. So these numbers are actually quite high, and in fact, may be a part of the reason why patients end up dying related to their liver disease if in fact they're not transplant candidates. The other issue, and this has been brought up before, is that we give therapy and it can control liver inflammation, but in fact, in many instances, it doesn't do anything for the side effects that come along with AIH. And we do know that patients have significant, what I call extrahepatic symptoms, meaning fatigue, joint pain, even increases association with depression, itch, anxiety, and poor sleep along with this disease as well. Now, I put this on the slide on purpose to make a point, corticosteroids. I'm preaching to the choir about how problematic steroids are, and I could put a long list of cause and effect of side effects. Budesonide has helped, but again, I sat and told you earlier that we still rely heavily on prednisone to treat patients with AIH. Just to name a few issues besides peripheral swelling, water retention, confusion, propagation of fatigue, poor sleep, steroids tend to be a problem. The other piece is in our general population, of, at least in North America, steroids often will drive the development of peripheral insulin resistance or elevated blood sugars. It is not uncommon when I start patients on high-dose prednisone because of severe liver inflammation, if they're over the age of 55 or 60, with other things like high blood pressure or kidney disease, but also then to develop diabetes after I start that. Unfortunately, it's somewhat of a necessary evil. So since we're talking about steroids, let me ask another poll question. Are you currently taking steroids, and that could be either budesonide or prednisone, as a part of your current treatment for AIH? We'll give another 5 to 10 seconds because this too, I think, is another important question. Looks like we have just about everyone. I'm going to end the poll and share the results. And not surprisingly, close to 40% of the people that are on this call today are still taking prednisone and budesonide. And the question is, well, where are they in their treatment? Could they have just been diagnosed and we have a lot of new patients with it? That's very possible. However, I want to show the next slide. We did something similar like this and looking at prednisone usage last year when we surveyed patients about their prednisone usage. And really just in all simplicity, how you can read this bar graph, these years are years after AIH diagnosis. And below that tells you how many patients are in those groups. And the percentages then represent the percentage of patients taking either prednisone or budesonide. And I want you to focus getting beyond 5 years. We still are having over 30 and upwards of 40% of patients, even though the number goes down, but still a very similar proportion of patients depending on prednisone or budesonide as a management strategy for their disease. This is concerning. It's concerning for a lot of reasons. And again, one of the big pieces that I like to share with patients, this was a publication from a few years ago, looking at patients with rheumatoid arthritis, which also depend heavily on steroids. It used to be thought, and I tell my patients, low-dose prednisone, it infers a significant amount of risk, no matter what. And even if it makes you feel better, there is a risk that comes with it. And what this data shows is in 2 different healthcare databases, having even less than 5 milligrams of prednisone daily increases your risk in with 1 year of follow-up of being admitted to the hospital for a significant infection. So we know there is something more to prednisone than just immunocontrol. It can be a significant factor for increasing the risk of bacterial, viral, or fungal infections as well. So another reason we need to try to figure out a way to get away from corticosteroids. Other patients that need better treatment, again, I want to zero in on our high-risk groups, particularly those patients that are at high risk of death or transplant related to their liver disease. So what are they? As a clinician, when I see a patient, I automatically itemize a patient into one of those groups, just so I can, again, tailor my strategy of aggressiveness to control. I look at my patients that are male a little bit different. Those that have cirrhosis at the time of presentation or when I first meet them. Patients that have persistent abnormal liver tests that are hard to control or require multiple therapies. And then even patients that are young onset tend to have a little bit more of aggressive disease. And then much like you heard with Dr. Bitterman, patients of color tend to present with advanced fibrosis and actually then may also be harder to control, at least in some data groups. Other important groups not to be left out are the patients that are steroid dependent for the reasons I just told you. Those patients that just can't tolerate any of these therapies, and I do have them as well. Patients that are limited by the side effects. One thing that we don't talk often about is because low white counts, these are side effects related to immunosuppressant medications, limiting how much I can increase that medication. And then those patients that despite therapy, they have progressive development of scar tissue or other disease-related side effects that are just poorly controlled. Moving into the idea of what is on the horizon or what do we have available now? This slide actually highlights a strategy that we haven't talked much about. It's B cell depletion therapy. B cells are cells that are important in the priming or activation of lymphocytes. So these 2 cells are very important for AIH. Sometimes attacking the B cell is important because a lot of our other therapies attack the other side of the equation. And right now we have rituximab, which I shared with you a little bit ago. Rituximab as an IV therapy that is kind of left to be the last line of defense as a strategy to control inflammation. And in fact, there's really only 30 patients that are published in literature in terms of the response to rituximab. And it ranges everywhere from 60% of improvement to 100% of improvement, depending on what paper you look at. Right now, though, rituximab as a salvage therapy is how it's listed in the guidelines. It has its own side effects and other potential as well. We did a little experience here at IU where we've treated now 8 patients with rituximab. And we've had results all over the board, but I would say generally speaking, about 40–50% of patients saw some improvement of liver tests and reduction in steroids, but not all of them. Another B-cell depletion therapy that is not listed, but to talk about, is a current medication that is being utilized in clinical trial. And this is something called an anti-BAFF inhibitor. BAFF inhibitors have been known to be a B-cell blocker to prevent the proliferation, the production of different inflammatory substances. Novartis is the manufacturer of this compound, is currently in clinical trial, and I'll share later with you, this is the only drug that is in current clinical trial, at least available here in North America. Outside of the things that I highlighted with you, we look for other strategies outside of just limiting the function and number of autoreactive inflammatory cells, or even blocking the action of pro-inflammatory substances. But I said, again, there's not much else. I will then potentially think about how can I layer other medications? And I thought it was brought up earlier. For patients that are not responding to therapy, I often will double down with other therapies. That means that I will combine therapy, meaning the addition of CellCept plus Prograf or azathioprine plus Prograf with addition of prednisone. So in fact, I can have patients that are on 3 different immunosuppressants. And for many of these patients, if I'm scrapping and fighting to try to control inflammation, there is a ceiling, I think, that we have to be very careful of. One is over immunosuppression, increasing the risk of significant side effects related to infection, but also is it worth it to try to control inflammation to prolong the time for either needing liver transplant or death. I'm going to shift gears because there is another avenue that is of tremendous interest and has been listed in our governing guidelines for AIH, but not a lot of work's been done, but I think work is on the horizon. And this is that enhancement of not suppression, but more regulation of the immune system, hopefully with a less toxic strategy. And to talk about that, I want to tell you a little bit about another cell that's important in the immune response. These are called regulatory T cells. And again, this is an advanced immunology lesson for patients, but I think you can understand these regulatory T cells, again, can restore balance to overactive B cells or cytotoxic T cells that are destroying or injuring liver tissue. These cells are important in that local environment to basically tell them to stop. These cells are also very dependent on a molecule called interleukin-2. You don't have to remember that, but what's important is if these cells are dependent on interleukin-2, the idea is, well, if you can give interleukin-2, could it help to enrich Tregs? And possibly, we'll talk more about that. But Tregs have been studied in AIH, and actually there is some conflicting data that T regulatory cells may either be diminished or not functioning appropriately in AIH. Again, there's more data hopefully on the way to better understand this role, particularly as we're thinking about therapies that may impact this avenue of AIH treatment. This was a publication from 2018 and looked at 2 patients. This looked at patients that were hard to control. And in fact, the investigators actually did an off-label use of interleukin-2 to try to enrich the Treg cells of those patients. You can see the demographic breakdown of these 2 patients. It's not so important, but I do want to call out that these patients were on significant amount of therapy, meaning they were on tacrolimus and CellCept, as well as a high dose of prednisolone. But also on the other patient, again, CellCept at a reasonable dose, but also 15 milligrams of prednisolone as well. And actually, when they gave interleukin-2 to these patients, they saw no adverse events, which was really exciting. But only one of those patients actually saw significant improvement in their AST and IgG, getting into normal range. But the first patient did not. They actually saw in both patients, though, the Tregs increased significantly. And although this is a 2-patient study, I think it highlights the possibility that it actually could be a strategy to help some patients with hard to control disease. Another strategy that we're very interested in, and if you follow with the AIHA online, we asked recently about mesenchymal stem cells. And just a very quick overview of mesenchymal stem cells. These are cells that are found in many different adult tissues, can be bone marrow, fat pads, even umbilical cords. These cells are very unique. And in fact, in a number of different studies that have been around for the past 10 years, these cells do something different. They pump out a lot of different anti-inflammatory molecules, but they also locally can target other cells in the immune system and basically downregulate them as well. They also can then enhance the development of Tregs, which I told you just a few slides ago. Tregs can also help to instill some homeostatic balance, again, minimize that balance of inflammation. MSCs have been studied in other autoimmune diseases. And in fact, I said there's been 10 years of experience and just a few studies looking back, even back to 2013 and 14 in lupus. Maybe 3 to 5% of our patients have lupus on top of their AIH. Some of you may not know what lupus is. It is an autoimmune connective tissue disorder that sometimes, in very rare cases and severe cases, can impact the kidney function. And in fact, that's what these papers looked at to see in patients that were having significant kidney injury, did mesenchymal stem cells help to improve outcomes of patients with lupus and lupus nephritis? And in fact, we saw some response in about 60% of patients in both of these studies. Unfortunately, they saw only some improvement in the second study, but only 8% had no response at all to MSC. The other important part of this is this therapy was actually really well tolerated and seemed to be possibly durable, but ultimately do need to understand when in fact you need to redose MSC as well. So our idea is to give MSCs to patients with autoimmune hepatitis. Again, this is a similar cartoon to what you've seen before. AIH is represented here with liver cells in the orange type of shade, with inflammatory cells with these red dots or red nuclei in them. With the transfusion of mesenchymal stem cells given peripherally, we actually can have these cells maybe tracked to the liver and actually to help abate or cause the inflammatory cells that are overactive to quiet down. We are very optimistic about it, and I'll be telling you a little bit about this more in our AIHA State of the Union address, if you will, and how the AIHA is involved with a manufacturer of MSC and how we're planning to do other studies looking at MSC and AIH as well. But this will all be done in the auspices of clinical trials. And I thought it was really important to understand that despite that we don't have new therapies available widely yet, there are things that are looking towards clinical trials, and MSC is one of them. The interleukin-2 is also another one of these. But clinical trials, for those that aren't aware, is basically where we do studies at mostly made academic centers. Also, some private companies do clinical trials as well. But basically, it's helping scientists to meet volunteers to help answer treatment questions. And again, for us, it would be whether a medication works better than standard of care. Again, the goal of clinical trials is to look for safety, but also the efficacy and understand the side effects of new compounds, or even study new populations. It's often identified as the safest and fastest way to find new treatments. And in fact, clinical trials are also often governed by the FDA, which helps to ensure safety of the patient participants. And I just want to make one key part of my talk is patients out there with rare diseases should consider clinical trials if they're available. But who are they? And it's actually those patients that really standard therapies, the ones I just listed, are either inadequate or they're not working or you have significant side effects. Using rare disease patients to be involved will help to mobilize the understanding of this disease, even in fact, if that compound we're using for clinical trial doesn't work. And I think this call to action to patients, at least in this group, is males and patients with cirrhosis, those that are hard to control, and even the young onset and people of color should be considering clinical trials, and in fact, when they are available. Again, the other important groups, those patients that are steroid dependent and intolerant to therapy as well, should also be looking at these pieces. I will say too, one thing that we've been really advocating is when clinical trials for AIH do come, we not only do we need to look at liver inflammation, but we need to look at these side effects related to this disease as well. Much like we talked how significant fatigue is, we need to understand how these therapies may in fact impact or help fatigue in the long run. As we wrap up here, may I ask a question as well, because this is a little bit of a new idea for AIH patients because we've had very little activity in the clinical trial space for so long. Would you be willing to participate in an AIH clinical trial? And that is to be answered if in fact you were eligible for one, just for us to better understand. Just a few more seconds. And I think this is really good news. And in fact, most would consider a clinical trial. I think one of the biggest things that comes after that is, well, where? And again, we have patients that are all over the world and all over North America, varying distances from subspecialists and academic medical centers. So we realize that is an issue, but those are pieces that we are going to have to try to get over those barriers. If in fact we can get enough patients to be recruited, because really that's the name of the game, is to complete the trial, complete the analysis, and try to understand if that new agent has any significant impact on the disease. If you look at clinicaltrials.gov, this is a resource that I would invite anyone to look at. You actually can search based on the disease state. You can search for autoimmune hepatitis, and you'll find there are 56 studies that are listed. And at first glance, you may be very, very excited. Unfortunately, if you really read the fine print, many of these are natural history studies or imaging studies or database studies, which really, it's great to collect data for autoimmune hepatitis, but there is really no movement in terms of treatment or strategies to better control disease. And in fact, a lot of the drug trials that are on there are international, particularly in China. And of some of them that are drug trial, also many of them have been completed or they were terminated early. And in fact, some of the more recent one that even Indiana University participated in the past 5 years, that data has been collected. However, it hasn't been written up. And again, we're hoping that there will be another wave of treatment coming soon. Right now, it's somewhat dismal that there is really only one new treatment in the U.S. that is currently enrolling at a number of different academic centers across the U.S., and that is the BAFF inhibitor therapy made by Novartis. So in conclusion, the need for new or emerging therapies as opposed to current or old therapies is quite immense if you really break it down to the patients that need this. And I think one challenge is that changing treatment dogma can be very hard. These medications are established. I'll be honest with you, the data is not tremendous in terms of the number of patients or the long-term follow-up. However, most hepatologists, and many of you may be embarked in this conversation, it says, well, the medication's working because your liver tests are normal. However, you feel poor. So is that really a good clinical change? Is there more to the treatment of this disease than just numbers? I highlighted two different strategies, B-cell depletion and Treg-centered therapies, including IL-2 and MSCs that may have potential for the future. And as an organization, I'm excited to see that maybe there will be new opportunities for patients to be involved in these studies, clinical trials, and maybe the development of a new therapy in our lifetime. I do want to highlight, though, a perfect treatment doesn't exist. But if we had to describe one, I think we should see it as easy to tolerate. It should control inflammation very well. And we should know for a fact that it limits the progression of fibrosis or even removes fibrosis, which we don't talk about enough. But it also improves the symptoms associated with this disease. And in fact, and one of the most important is it works uniformly across all different patient groups. Because as of right now, we just haven't had that data from our current dogmatic approaches to AIH. I want to thank you, and I'll be happy to take any questions that you may have. I saw that there is a number of things in the chat, and I'll just walk through them backwards. The idea is it possible for people outside the U.S. to be included in those clinical trials? That is a major challenge. So again, just, and I'll highlight a little bit this later, is for our clinical trial that we are planning here at in IU, patients will have to be able to make upwards of 6 to 8 clinical visits for the administration, but also the follow-up of those medications. So I think it'll be near impossible. But the hope is to spread the need for these type of trials, and not only have trials here in the US, but also shared trials in North America or in Europe as well. Some other question, what's the comparative risk of steroids versus immunosuppressants for the risk of hospital admissions due to infections? So I get this question a lot. So patients that are on standard therapy with just azathioprine, I have patients that firmly believe if there's an opportunity to get sick, they get sick. I have other patients believe that, in fact, they don't get sick at all. Some of the data that we have, and honestly, I'll tell you, it's not very good, but data from inflammatory bowel disease and immunosuppression that's been better looked at, The idea is with standard immunosuppression, azathioprine, CellCept, Prograf, we don't think that we enhance the risk of bacterial infections substantially. I think that's probably somewhat true. Honestly, I don't know if it's completely normal in terms of your response to infections and being able to control those. I think one of the most important pieces that increases the biggest risk for infection are steroids. Now, I think the logical follow-up to that is, well, how about budesonide? Is that also similar? And I don't know. I will say the makers of budesonide, I think there is interest to potentially to understand how can we use budesonide long-term as a strategy. And I'll be honest, when I look at the literature for budesonide in inflammatory bowel disease, after a year of budesonide therapy is not terribly effective for control of gut inflammation. However, I have patients that have been managed with budesonide monotherapy just by itself because they didn't tolerate anything else, and they're doing just fine. So I think there is some important pieces to that. There's a lot of other things that people talking about breaking up with prednisone. I think that's funny. Steroids equals poison. Someone asked about nausea after years of azathioprine common. Typically any GI related side effect at any time point can be related to azathioprine. I think this is also just a really important piece not to settle in terms of therapy, and discuss this with your clinician that manages your case. I tend to have an approach where I'm very aggressive of shifting therapies because I like to know if that medication is contributing or not. So I would advocate talking to that provider. One thing too is in patients with GI symptoms, sometimes a simple switch from azathioprine to 6-mercaptopurine may all that is needed in terms of kind of squashing the GI symptoms. However, a major pivot or switch to things like CellCept or Prograf may be appropriate as well. Let's see here. Someone said I actually had massive inflammation, but budesonide worked fine in reducing. I had severe acute onset. So that's great. And again, I think, just a word of caution though. One thing is with hepatologists, when we see massive inflammation as described, I think many of us don't want to take any risks for things to get worse, particularly with patients that have acute severe presentation. And just for those following at home, acute severe is when you have an elevated INR at presentation, meaning your liver is just not working. So typically 1.5 or higher as a marker of hepatic impairment. So it's those patients that we watch very, very carefully. And in fact, many times we actually work them up for transplant in parallel with their diagnosis. In fact, just in case the prednisone or budesonide doesn't work. So why don't I stop there, Aaron, if you'd like to take back over. I thank you for inviting me to give this talk. And again, I do want to say, I give these talks often. I share this with patients often, but I also will just say, listening to you guys talk during the patient panel, it is reinvigorating. In fact, just sharing that information can be very motivating for providers and those in the field. So that's why I want to continue those conversations and share those with your providers as well. So thank you for enlightening me.